Okay, so we are live. Talk with us. I'm muting myself. Over to you. You can take over from here. Dr. Itzaz, are you with us? Am I audible, everyone?
Am I audible?
Yes, you are audible now. You're perfectly audible. I'm muting myself. We are live. The meeting has started recording as well. I'm muting myself. Over to you.
So, Assalamu alaikum, everyone, and good evening. So, how are you all people? How are you guys? Fine?
Walaikum salam, sir. Alhamdulillah.
Okay. Yesterday we have completed the anterior approaches. Alhamdulillah. So, today we are going to start the posterior cervical approaches. Okay. Any question about the yesterday's section?
No, sir.
Anterior section, any question? This question, my question is not pertaining only to you, Dr. Sana. There are a lot of other peoples also here. I think you are representing all of the other peoples as well. Yes.
Yeah, I think Dr. Sana has unofficially become our ambassador.
That's good.
Hello.
So yes.
Yes. Unfortunately, I didn't attend the last two sessions, so I will check them, and if I have any question, I will post it on the group.
Your voice is not clear, Dr. Ayman. What you are saying? Can you please repeat?
Unfortunately, I didn't attend the last two sessions.
Okay. You didn't
Okay.
attend last two sessions.
Yes. I will
Okay.
watch them on YouTube, and if I have any question, I will write them down on the WhatsApp group.
Okay. Put all these queries and questions on WhatsApp group. Inshallah, we'll try to answer this one.
Thanks a lot.
Over your
Thanks.
link. Okay. So start. So what you are seeing on the screen, anyone who can interpret what is there? Yes.
Can I try?
Yes. Yes, Dr. Ayman, start. There are two
I see.
sagittal and lateral views, and
Yes.
three there are axial views. What the problems
Yes.
are there?
So there is cervical disc herniations.
In which one?
You mean the level?
In this one?
No, so the second one.
In this one? In this one, there is a cervical disc herniation is there.
Yes,
Yes.
I mean on the axial section, we can, make sure that or in some form of it.
Okay. There is also a disc herniation. And there's also disc
And
herniation is there.
yes,
And what
and
about
I
this
think
one?
there's this one. It looks like first arthropathy.
Excellent. Very good. So, what about the approaches to these all problems? Because there are a lot of problems. There are different problems are there. So, what could be the approaches? What is the problem in this patient in this image?
It seems like
think
it's
ligamental
ligamental
flavum
hypertrophy as well.
hypertrophy.
Dr. Shan is there, I think, and Eamon, you both are talking. So what you are saying? What's the problem with this one?
So in the first image, it looks like there is ligamentum hypertrophy at the back.
Excellent.
in the
Okay, good.
posterior.
In the first one, there's a ligamentum flavum hypertrophy. In the second image, that is the lateral view. What's the problem? There is a dual pathology. There is anterior compression of the multi-level, 3 levels disc herniation. Most there are 2 level. That is the, you can say the 5, 6, and 6, 7. But the 4, 5, there is also the problem is there, but mild. And the second, the posterior compression is as well. There is also ligamentum flavum hypertrophy. On the third section, that is the axial one, that is the central disc herniation is there. Look at here, okay. And the fourth one, that is the lower one, the left side first, foraminal stenosis is there on the cervical spine. You can see here at this one, this root has been compressed. On the last one, the fifth one, the lower one, the second one, the problem that the joint hypertrophy is there, facet joint hypertrophy, arthropathy is there. So look at here. Which joint is this one? Suppose that there is another vertebral body over here, so which joint will be formed here? Yes, Dr. Sana?
Facetal joint.
Sir, uncovertebral joint.
Uncovertebral joint, excellent. Facet joint will be here, that is the superior facet joint, inferior. These both two, when another vertebral body over here, it will form the uncovertebral joint. So yesterday we have seen that, look at here, that this is hypertrophied, okay, and this joint hypertrophy is there. So it causes the severe compression over the nerve root. So these are multiple issues over there. So what you say, what approaches could be there? All patient will go into the posterior surgical approach, posterior cervical, decompression, or
No,
foraminectomy, a laminoplasty, same.
according to the pathology,
Okay, in this one, the above superior one, what approach is ideal? Posterior one or the
posterior,
anterior?
I think
Posterior.
the best is posterior from anatomy.
Okay, what about in this one? What about in this one? The second one?
Recording is stopped.
Recording is now, why stopped? So what about in this one, the second one? Yes, please. There are two pathologies, the anterior and the posterior compression as well. Anteriorly, the disc herniation, the posterior ligamentum flavum hypertrophy.
I think you may have to do both from anteriorly and posteriorly.
Excellent, Dr. Shan. The ideal approach is that we have to go anterior and then posterior, anterior decompression and the fusion ACDF, but this is not ideal for ACDF. In this one, we will do the corpectomy. Yesterday we have seen, okay? And then posteriorly we have to do this one. But most of the time, some surgeons only do the posterior cervical decompression and fusion to decompress this canal and stenosis. And what about this one? The third one, there is a disc herniation over there. What approach is ideal in this one?
Anterior, anterior.
Anterior SCDF. Dr. Shan, what are you saying?
Yeah, and ACDF.
SCDF. And what about you, Dr. Eamon?
Me too. I said ACDF. I think it's enough.
SCDF. And what Dr. Sana will do?
Sir, ACDF.
SCDF करेंगे आप. Okay, and John Carlos is also saying that SCDF. Okay, excellent. This is that to make you people confused that how you are doing this one. Okay, this is SCDF. This is pure SCDF. This is not the posterior approach is there. And what about this fifth one, the fourth one? The foraminal stenosis is there.
The same. I think the same. I think the
We can
same.
do both posterior and anterior.
It's up to you. It's you are doing the easy go. You can do endoscopic foraminotomy and laminotomy you can do, and just posteriorly single level, and anteriorly you can also approach this one. But the posterior approach when we are doing the frontomy, this is the ideal case for that one. Okay, there are two school of thoughts. Later on we will see. And what about this one?
Posterior approach.
Again, the from anatomy is there, but you need drill because it has the osteophytes. Okay, so let's start. There are since yesterday when we are talking about the anterior and the posterior approaches, usually we are covering the subaxial spine. So you should be clear about that we are talking about the subaxial from C3 to C7. C1 to C2 will do separately. Inshallah, tomorrow we'll do the C1, C2 approaches. We'll try our best to cover all these approaches, but anterior and posterior all approaches, these are related to the subaxial spine. Okay, so mostly there are three approaches posteriorly. One, there is foraminotomy, or the foram, that is the laminotomy is there. Second, with the help of easy go or open, it's up to you. And if you have the good expertise in easy go endoscopic, then we will prefer the easy go because it gives a lot of help in the post-operative recovery, and the patient will get less pain as compared to the open one. Second is the posterior cervical decompression and fusion with the lateral mass screws. So it is another approach, good approach. We'll see that how it's being performed and what are the types of lateral mass screws. And third one, that is the laminoplasty, cervical laminoplasty. Usually we do the open door, and there is a two one, the open door, the hinge type, and the closed doors are there. So let's start. Okay, this should be the position of the patient when while we are doing the surgery of the cervical spine. The patient will be prone, and the shoulders will be retracted downward. There will be the flex position should be. The patient should be mildly flexed, neck should be flexed because it gives because the cervical spine has the lordotic curve. It will be little bit extension. It will give us less exposure over there, and it reduces the hurdles. That's why it should be more flexed as compared to this one. It's saying that 30, but you can go up to the 30 to 45. Mostly the standard is 30-degree flexion should be there because we need this area, this space should be clear and good exposure over there like this. This is curve, that is lordotic curve is there in the cervical spine. We need it should be open and should be clear. That's why we need a good position in this one. Okay. Then we in the anterior cervical spine approaches, we covered the muscles and normal anatomy. And in the posterior cervical spine, though we'll cover the normal anatomy as well while doing the exposure. But there is one thing that is important. The posterior cervical muscles are very important. It has three layers. One is the superficial, intermediate, and the deep layer. You know very well all that what is these are layers. Just there is a brief review of that one. The superficial one, only the one muscle, that is the trapezius, the midline, and the laterally. And intermediate, look at this one. This is the superficial muscles whole, that is the trapezius muscle. Uh, and then just posterior lateral to this one, there is a intermediate muscle. Uh, there is a one muscle, and then this lateral muscles. Intermediate muscle is most laterally of that one, that's the splenius capitis, and the deep layer muscles, there are multiple, that is the semi-splenius capitis. And when we are going above cervical, upper cervical one and the lower cervical one, they have some different kind of the muscles. If they are upper cervical muscles, we can have some part of the sternocleidomastoid mastoid muscles laterally because there is a origin of that one. The mastoid is there. Okay. Then we have the splenius capitis muscle. that has been cut down, and then there is a semi-spinous capitis muscle is there, and this one that is shown here, it has been cut down. Then we can see the deep muscles is there. Medially, there is a rectus capitis, and there is a posterior minor. When we'll go downward a little bit, there is another muscles are there. That is the rectus capitis, posterior minor and posterior major. There are two muscles of the rectus capitis. One is the minor and the rectus major one. The major one is posteriorly, and the minor one is anteriorly and superiorly placed. Uh, and the lower muscles, scalenus capitis, another one. It is also, we have seen this same muscle is there that has been cut down from here. Okay. So longus capitis are the deep muscles of that one that is very related to, it is related to the posterior peri, but you can say the spinal area, as the muscles are the perivertebral area and the anterior side. So it is related to that one. It is the counterpart of, you can say, the longus colli muscles, the longus first capitis. Okay. So after the setting these muscles, it is very important we like get the exposure. But it's up to you, and it up to the us and our on the surgeon that how they are doing. Suppose that we are doing the C4 5 foraminotomy is there. So our exposure will be limited. The lower muscle will be exposed, the upper muscle will not exposed. But our target is lateral mass screws, posterior cervical decompression and fusion from C3 to C5 and C6. Then most likely the all muscle will be exposed and all area is exposed. So when we are doing the this one, this is the case. You all know very well, you all interpreted it very well, that the one approach is that is the foraminotomy. So the indication of that one, what is the indication of foraminotomy? Yes, please. What is the indication of foraminotomies?
Foraminal stenosis, I think, only, not central.
Foraminal stenosis is there, yes.
And
Yes.
no cord compression. And no cord
No
compression.
cord compression. That is contraindication. Cord compression is contraindication of this one. Suppose that the anterior cervical disc is there and there's a central disc, then it is contraindicated for foraminotomy. But I am talking about the indication. Indication is only one that when we
Yes,
have
yes.
the foramen.
I mean,
yes, you know. Just I am repeating it. Sorry.
What I have meant, foraminal stenosis only without central cord compression.
Yes, this is only indication. You are right. But when you should know there are two school of thoughts. One is saying that there is a soft disc is there that is not calcified. Then we can do the foraminotomy with the help of open or endoscopic. We can take that disc. And second school of thought is that one that though like in this case, okay.
Pronto? Buongiorno, mi dica. Sì, tutto bene?
Dr. Gyam, please mute yourself.
I have
Thank you.
muted them. I'm sorry for the interruption.
Okay. And second school of thought is that because look at here, it is actually the disc and foramen is anteriorly compressed, not posteriorly. But when we are doing here, it is bit difficult to address this level, but it is to some extent it easy. How do you see when we target is this one, this level at the hair side will do the laminotomy or the laminectomy, then approaches here. There are two school of thoughts. Suppose that it's the soft disc, then we can take out this disc portion easily. But suppose that it is a calcified disc is there, then it's very difficult to take, then go from directly to the address this one. Then what is the approach? Then approach is that just open this after doing the laminotomy, then you have to open the foramen, wide this foramen of the nerve root. Don't address this. This is school of thoughts. So in foraminotomy, we do two things. First, we have to address the disc. If it is the soft one, then we will take out this disc as well. But when there's the calcified disc is this, then it's very difficult to do posteriorly and doing the laminectomy. Then we have to open the space of the root. Okay, if there is a bone is there, then we have to some part of anterior and the medial part of you can say the facet will be dissected, and then the root will be wider. Okay, like in this case it is very difficult to address this one with the help of you can say the posterior level and the foraminectomy, laminectomy and the foraminectomy. What you will do and what we will do actually when we're doing posteriorly, we can do only the foraminectomy. This one with the help of drill, high speed drill should be there, that we can remove this portion of this one and remove this portion. In both cases, you can do anterior approach, and with the help of you can see the drill, we can take these out too. Okay, so this is our target. In foraminectomy, what we do? This will be our area. That is, you can see the lateral 1/3, just adjacent to the lateral mass. We remove this portion, and second approach is that we have do the whole laminectomy is there. One is the laminectomy. One approach is that we are doing the laminectomy, or you can do the hemilaminectomy of this one. And second is that we are doing the laminotomy. Laminotomy means just make a hole over there with the help of drill, then address this one. Don't remove this whole lamina. Okay, so if you are doing the laminotomy, the target is only this one, this side, and just part of you can say the facet, not whole. The 1/3 of the facet can be removed, not all one. Okay, try to be careful about that. So if you are doing the laminectomy, then it is easy, and this whole root can be addressed. And if you are approaching this disc, we will remove this disc, and with the help of a hook, we have to retract this nerve root, and then with the help of hook, you can take this disc and ronger. With the help of ronger, you can disc. But if it's difficult, then just widen this nerve root area, foramen area, with the help of little bit drilling of the anterior part of this facet. That will be easy. In this case, it is pure that we cannot remove the pathology completely, because anteriorly and posteriorly it is whole hypertrophy. Our target is to do only the foraminectomy is there. In this one, we can do laminotomy and laminectomy. Then with the help of drill, we can create a space more in this one, so that the root should be cleared in this one. Okay. This is the just a rough view of the skin incision, that how we will give incision to this one. That will be the midline, and it's up to you that what level is there. Most likely the foraminectomy is the single one we are doing, but multiple levels can be done in this one foraminectomies. This is the picture of this one. That axial view, this is axial view. Our target is this only one. It has only the foraminectomy, laminotomy is there, not complete laminectomy has been done. Look at here, and this is the nerve root that is going, and with the help of hair, this is the cord. This yellowish is the ligamentum flavum. The ligamentum flavum has been removed, some portion ipsilaterally and the midline and the lateral part of over the nerve root. Then what happened? The nerve root is there. We will see with the help of hook and the nerve root, that root is clear or not. If there is a root is compressed or not. If it is compressed, then with the retracting to this nerve root laterally, then you can do the portion of the disc is there. You can see the small portion over there is there, the bluish one. You can take out with the help of that disc if it is soft. So in this way, you can do the laminotomy and foraminotomy. But if you are doing the laminectomy, that will be easy. This level should be removed whole completely. Then you can address these all things. The advantage of the laminectomy is that it gives more space, and we can address the disc as well in an easy way. But the drawback is that it is the more deficit as compared to the laminotomy. Though there is no any disadvantage of this one, but as compared to laminectomy, it has that we are damaging the normal structure more. Otherwise, it is safe that you can do the laminectomy as well. Posterior cervical foraminotomy, that decompression is what are the pros and cons of this one? Decompression is load. Bilaterally unilateral nerve root can be performed on both sides. It's up to you that if there is on both sides, then we can do unilateral and bilateral. It is the motion preservation technique, because the cervical is more mobile part of our spine. That's why there is no any compromise over there, the motion. There is no any screw fixation is there. When there is any instrumentation and fusion, always there is a, you can say to some extent or mostly, there is a motion will be compromised. But in this one, we are not doing any kind of instrumentation and fusion. That's why frequently patient will be mobile in the normal way as the preoperatively. Does not help neck pain or may worsen it. Okay, the neck pain is less as compared to the other one, open long procedures like we are doing the decompression and fusion in the lateral master screws. But again, when we are doing the easy go, again, the pain is less as compared to when we are doing the open one. Patient may develop recurrent stenosis or herniation. Why? Because suppose that when the disc is mostly anterior is there for amyotomy and we are not addressing the disc too much, some portion is being removed or not removed completely. Again, there is a chances that patient can develop the same disc, can herniate it more, and the stenosis can be there. So this is the drawback. When the disc is been removed, then it's excellent. There are less chances of herniation. Again, stenosis will not repeat. But when we are not addressing the disc, only we are doing the foraminotomy, enlarging the foramen, that the nerve root passage is there, then the herniation is recurrent and can be possible. Okay. The second approach, that is the cervical laminoplasty. What is the cervical laminoplasty indication? Yes, please. Yes. What is the cervical laminoplasty indication? What happened? Am I audible?
You are perfectly
Yes, sir.
audible.
Yes, sir.
Then why you are silent? So, you people, just tell right or wrong. Either you are right, either you are wrong. Then just speak, please, because it will give us a lot of idea. Maybe some point you know very well and it's good. Maybe some point I don't know it. I will learn from you people, and you will learn from me. So, what you think? What is the indication of cervical laminoplasty, and what is the contraindication of cervical laminoplasty?
More than one posterior level stenosis.
Yes, what are you saying, Dr. Eamon? You are there?
Yeah.
Yes, what are you saying? What is the indication of cervical laminoplasty?
For a redo
I'm
case,
just guessing, not sure. I think more than one posterior level stenosis.
Okay, cervical stenosis. Excellent. Cervical stenosis secondary true?
I think
Cervical
bony
stenosis,
pathology.
there are a lot of causes of cervical stenosis. Cervical stenosis
Bony
secondary
pathology.
to
Bony pathology. Bony pathology, like
Is it joint
canal
hypertrophy?
stenosis.
Sorry, ligamentum hypertrophy. Yes, Dr. Isra, you're right. Ligamentum flavum hypertrophy, cervical stenosis secondary to ligamentum flavum hypertrophy, multiple level. Yes, excellent.
congenital canal stenosis, like a small canal,
Excellent.
small body part.
Congenital cervical canal stenosis is there. You can do the cervical laminoplasty. Very good. Another one? Congenital cervical canal stenosis, ligamentum flavum hypertrophy, because these two both causing the stenosis. And any other one? Multiple cervical disc herniations are there. You can do the cervical laminoplasty. If you are not doing anterior approach, there are 3 to 4 levels are there. Then you can do the cervical laminoplasty. If there is a cervical stenosis is there, canal stenosis is there. Okay. You can do the cervical laminoplasty plus minus is there. If the old age patient, then we will avoid the cervical laminoplasty in the patients of old age. In the case of OPLL. But again, if the patient is there, the OPL is there, though the OPL is not in the young age group, but the middle age group, and the lordosis is intact, then we can do the cervical laminoplasty. Okay, it means the cervical laminoplasty, we can do the cervical stenosis. There are a lot of causes you all told us one by one. Okay. So what are the types of cervical laminoplasty? Yes. Yes, Dr. Yusra, Dr. Ikra, Dr. Aman,
I saw
Dr.
unilateral
Sana.
laminoplasty.
Yes, please. What are the types of cervical laminoplasty?
Unilateral laminoplasty.
Yes.
And
Open door.
Open door, excellent. Open door. What's mean by open door?
Sorry, sir, little knowledge regarding this.
Sir, open door unilateral laminoplasty.
Open door and unilateral laminoplasty. And if there is an open door, there must be the closed door.
Open door is
Double door.
used.
Sir, double door.
Double
It's
door. Okay, open door, the French door, double door. Yes, you are right. Okay. The open door and the double door. So let's start. So after dissecting the muscles, after opening and exposure of the posterior elements, what should be the exposure of for the laminoplasty, and when we are doing the decompression the same? If you are doing the laminoplasty, multi-level laminoplasty, or we are doing the posterior cervical decompression and fusion, the exposure will be similar. How? What should be the what structure we should know that they should be exposed? Yes, please. Yes. What are these structures?
lateral mass. Lateral mass.
Okay, these are the lateral masses bilaterally. These are lateral masses. Okay, actually they start from here. I went more medially. This one. Okay, so these are the lateral masses here. Okay, so and what are this structure from here?
This is the lamina, and in the midline is the spinous process.
Okay, this is
Spinal lamina, I think.
this
Spinal.
is
Lamina.
lamina, and the middle portion will be, and this middle one be
Spinous process.
Spinous process.
this middle will be spinous process. So the most median and midline is from the spinous process till that the lateral masses, these are should be exposed. Okay. These all should be exposed. If these are not being exposed, then it means we cannot do the laminoplasty. It will be difficult for us, and we cannot do the posterior cervical decompression and fusion. So what happens actually? These, because in the lateral mass is necessary for exposing when you are doing the lateral mass screws, and the laminoplasty, it is good because we should know the lateral margin of this one. So what we do laminoplasty, in the laminoplasty, you can say the open door in laminoplasty. This is the portion of lamina. What is, why not smacking? Correct one. We cut down the lamina. Okay, we cut down the lamina. And what is canal actually? Where is the canal actually? This is the canal area. Okay, this is the canal area. And what is the purpose of this one? That we have to remove this stenosis. We have to remove this stenosis. So how we'll remove? Look at here. I am showing the other pictures of this one. That will be easy for you. So look at here, these two. These two. Okay. Can you see in this picture? What is the problem? On the left side. What is the problem in this one? Yes, please.
Disc herniation.
Sorry?
Disc herniation.
The voice is not clear. Who is there?
Dr. Ayman. I'm saying, is it
Okay,
disc
Dr. Ayman,
herniation?
what's the problem in this one? Yes?
Disc herniation.
Disc herniation. So where is the disc herniation? And what is the problem in this one? In this one, what is the problem in this one? Yes?
I mean, no spaces around the cord. The canal is stenotic.
Excellent. There is a canal stenosis. Look at here. This is the canal, this one, and the cord is relaxed. This is the spinal cord. These are nerve roots. This is disc anteriorly. Posteriorly, it is the vertebral artery. This is the lamina, and this is spinous process. This is why I showed you, because it will help you a lot to understand this one. So look at here. It is a normal one because the canal is open. There's no any compression is there. There's a space and the good space. But in this picture, look at here. There's a canal stenosis there. There's no space for the canal. So actually what we do, this is the area that we have to do the laminectomy. Sorry, make a space over there from here. Okay, it's up to you. Suppose that if there is only left side stenosis there, left side multi-level stenosis there, or there is a congenital canal stenosis is there. So then it's up to you that which side is being opened. But when there is a only left side stenosis is there, multi-level, then you will open thoroughly, completely of ipsilateral that lamina and contralaterally half lamina. Suppose act like this. When we are doing open door, this completely, you will completely open this lamina, and that contralateral lamina will be open half, like this one. Okay. Are you clear? Are you getting my point? Am I audible?
Yes, you are audible.
Yes,
I think they are not clear.
You are not clear. Okay. Why not? It's easy. So when you are doing the open door, what happens actually that one side will be opened completely. Suppose that if there is a pathology on one side, more likely, then it will be completely opened. Or when there is a canal stenosis there, most likely we open the right side completely. Complete opening of the lamina one side, or complete drilling of lamina one side, and contralateral side and other side, the lamina will be opened half, not completely, outer side of the lamina, because we are creating the hinge. Okay, look at here. Okay, look at here. This side of the side of the lamina is completely opened. We opened it completely, and this, look at here, this side is completely opened, this lamina with the help of drill, and this side half opened, this half cut. 50% of the lamina is being drilled on the contralateral side. Then we will open the ipsilateral completely open lamina contralaterally. Then we will put the plate over there. Look at here. This portion is will completely removed, and this will be half removed. Look at here. Then we will open this lamina. We will remove this lamina contralaterally, and then we will plate a we will place a plate over here. Then it will give a more space to the spinal cord in this level. Look, now you are getting my point.
Yes, sir.
No, it is easy. How it's easy? You have to this lamina will be drilled completely from here. Okay, the lamina will be completely here drilled, and this lamina I am making the pointing that one will drilled, not completely. I'm making point in the black. Suppose that this black side, we will not drill the lamina completely. 50% of lamina will be drilled. You can say the superficial part of the lamina will be drilled. On the blue side, we will drill the lamina completely. Okay, we will this lamina completely. Then what happens? There are two ligaments. One, there is interspinous ligaments. Yesterday we have discussed. Then the ligament in between these two, that is called the interspinous ligament. And other ligament is that is the supraspinatus ligament from here to here. But when you are opening this one, it will not allow you to open. There again two school of thoughts. So that rupture this interspinous ligament, not supraspinatus ligament. Here it will be the interspinous ligament, some portion of supraspinatus ligament, and then interspinous ligament. When you will remove this one from superior to downward, then you will open this side where the lamina is completely opened. You will retract with the help of Penfield and any structure, hard one, to open that one. It will give a space. And to give a space, you will put the plate over there from one side of the lamina at here and then at the lateral mass screws. Okay, now it's clear. Now it's clear.
yes, yes, sir.
Look at here, this one. This one. This lamina has been completely removed and this partially removed. Then we remove this one. We took it above. Then we placed a plate, one side over the lateral mass screw, other side over the lamina. Okay. What kind of a plate you will place? What will be the size of the plate? Yes, anyone who has the idea? Anyone who has the idea? What will be the size of the plate? Yes.
Mini plate.
And so,
That
yes,
mini plate.
please.
Mini plate.
Mini
2
plate.
milliscopes.
There are two plates actually. That's why I'm asking the question. There are two plates. If it is mini plate like this one, it is this plate is there. There is no any graft over there. Some plates has the adjacent graft over there that will lodge in between the you can say this lateral mass as well as the lamina. It will create more space. Okay, when there is a no graft, then it will be easy for you that 12 plate you can place over there. Okay, but when it is a graft with that plate is there, then there is a marking over there at that plate and graft. Then up to you now that how much space you want to create. Okay, how much space you want to create. Suppose that what happens actually in the 12 plate associated with the graft. What I'm saying, there's a 12 plate with the graft is there. That 12 plate with the graft, it will give you a space of 0.5 millimeter. What? 0.5 millimeter. Remember this thing, because when you are some people, if they are going to the exit exams, the examiner can ask that how much space you are going to create. When we are placing the 12 plate with the graft is there associated, the plate has the graft, that 12 plate will give us 0.5 space. Now it's up to you how we have to calculate that how much space we are going to create. It's very easy. You know very well that what is the normal size of the canal width. What is the normal width of the cervical canal?
10 to 12 milli.
Sorry?
10 to 12 mm.
10 to 12. Yes, anyone else? What is the normal cervical canal diameter? Yes, please. Dr. Yusra, Dr. Lalit. 2 centimeter. Who is saying that 2 centimeter is there? 15 to 12, 20 someone is saying we size it during the operation. Excellent. You will do the size in opening. You have to calculate the canal when you are preoperatively and postoperatively. Someone is saying 15 always talk about in the range, not the exact one, because most of the time we are not confirmed that what is the exact size. So always talk in the range. So the canal size is 12 to 16 mm. 12 to 16 mm. What we say, 12 mm plus minus 4-5 mm. 12 mm plus minus 4-5 mm. It means normal, the less will be, the minimum will be the 12 mm. The most likely it will be 16 mm. So the normal canal diameter is 12 plus minus 4 mm. So you remember this one. If it is less than, it is the 10 to 12, it means stenosis is there. If it is 8 to 10 then it is the moderate stenosis is there. But when there is a less than 8 there is a severe stenosis is there. So remember these diameters. So what happens actually, suppose that you have calculated the diameter of canal operatively, that the patient has the canal stenosis of about, there is a 11 or the 10 Suppose that is 10 Now what you know, what you need? You need about the minimum 2 millimeter space. 2 millimeter space. Are you getting my point?
Yes, sir.
2 space.
Yes.
So when you are applying, suppose that when you will apply 12 plate with the graft in this patient, Will you get the required space?
No, sir.
No, the answer is no. What will be the space if you will apply the 12 mm plate? If there is a graft is there, it will be 10.5 mm. 12.5 mm. So ideally, what happens actually if you apply the 14 mm plate, the plate when there is a more one, each plate has 0.5 mm more space. Suppose that if you are applying the 12 mm plate, it will give you the 0.5 mm. The lower standard size is 12 mm. If you will applying the 13 mm, the size will be about 1 mm. If you are applying the 14 mm plate, it will be about 1.5 mm. Okay, when you are going to apply the 15 and 16 mm, it will give to 2 to 2.5 mm. So you should know this one. When there is a plate associated, the graft is there is marking over there that how much that plate gives you the space. Minimum it will give the 0.5 mm. When you will move forward above, the larger the size, the increase the space will be 0.5 mm per 1 mm increase in size. Okay, so if we have the 10 mm steno canal size is there, our target is 12 mm, then we'll apply to about 14 to 16 mm plate minimally, the standard size that one if we have the graft. If we don't have the graft, then no need to put that one. Okay, just tightly do the usually we put the bone graft. I did two cases. In that one, the one case I put it because here at our setups the plate with the graft was not available, so I put it this same plate over there, then I put the graft over there in that between the lamina and the lateral mass, and then I put one screw over that graft as well so that it shouldn't dislodge from here. So it is another one if it's plus minus you are putting the graft or not, because it will create the more space. Okay, so this is the laminotomy, that's the hinge one, that it, because this door that is the partially opened, it will create a hinge over there, over here there. So this one. And what is the second type of the laminoplasty is there? How we open that one? That is dangerous. Mostly the people and the most of the surgeons, they do not prefer that you can say that laminoplasty. So what will be that? Yes, please. Anyone who has that? Yes, yes, you're right.
Double door laminoplasty.
Double door laminoplasty. Double door, how it will be? Dr. Ikra?
We will open the laminas bilaterally, not on the single side. We will open it bilaterally and
Okay, there's a double door laminoplasty that you should open the bilateral lamina, then over you can put the graft. One another also there is approach is there. What one? You're right. There is a bilateral opening of this one. Then we will put a plate over there.
yeah.
What is another approach? Yes. Some surgeons that says that they split this spinous process. They cut down the outer portion of this one, special, then they split downward. They bilaterally retracted to this one. They open both one, half of spinous process ipsilateral on this side, half spinous process this one, associated with the lamina. Then they put a plate over here. Okay, this is second one, but this is not ideal because it can damage the spinal cord when you are going downward. So the ideal one is that the hinge, the open door, you can create a hinge one complete side, and contralaterally you have to create the hinge, or bilaterally, as the Dr. Ikra says, the bilaterally removal of the lamina, then place the door, that will be called the double door. Okay, got it? Any question? So what is the contraindication of this one? What is contraindication of laminoplasty? Yes. Anyone who can tell? In traumatic cervical spine injury, you will not do the laminoplasty. Okay. In old age patient, when the lordosis has been it is compromised, you cannot do the laminoplasty, because what happens, it actually limit the extension. Okay, so be careful in that one. So this is the again picture. Look at here, one side completely lamina has been removed, and other side we will do partially. Then we will lift this lamina. This is the graft. This is, you can say, the graft is there. Okay, and one portion, this will be the graft over there, like here, and this portion, this will be the plate. This is another type of the plate, bilaterally. Suppose that the inferior portion and superior portion, they both have the screws. One screw will be placed over the lamina, another one over the lateral mass. So how that the space has been created. Okay, this is the creation of the hinge that partially remove of the lamina. So posterior cervical decompression and fusion lateral mass screw. Yes, Dr. Kamal, you raised the hand, but we have the time because we started late. Just give me 5 minutes. We will complete in 5 minutes, inshallah. It's
Okay,
easy.
okay, okay.
So if you have the time.
No, I definitely have the time.
Okay.
That's okay. We can complete this.
So it is the last one, the posterior cervical decompression and fusion plus the lateral mass screws. So what is the indication of this one? Yes.
OPLL.
Multi-level.
Yes, Dr. Salim, you are very clever boy. That there is a OPLL, there is a multi-level stenosis there, congenital stenosis there. Traumatic patients, when we are dealing the traumatic patients, suppose that post-traumatic subluxation is there, we can do the posterior cervical decompression and fusion plus lateral mass screws. So these are some of the indications over there. Okay, the post-traumatic patients, suppose in this patient, when there's a multi-level stenosis, and suppose that there's a trauma patient has a subluxation, and then we can do the posteriorly, anteriorly and posteriorly both, and with the locked facet, especially when the patient has the locked facet is there, because anteriorly you cannot unlock the facet, posteriorly you have to open it. That's called the 360 approach. When there is a OPLL, we can do the posteriorly. Okay. So again, this is the same picture. You know the very well anatomy that this all posterior elements should be exposed. The spinous process, lamina, and the lateral masses, these all should be exposed, because there is a lateral part of the the lateral mass will be exposed, should be exposed completely, because if it is not exposing completely, then it will be difficult for us to put the lateral mass screws over there. Okay. So this is the same picture. There is the stenosis is there, significant. So what we do in this one, look at here, this is another picture. That is the canal is opening. This is the lateral view of this one. This is the disc. This is the body. This is spinal cord, and these are the posterior elements. This is the lamina of this one. This one, the look at here, the canal is adequate and opened about the maximum size and normal size. But when here, this is here, there is a disc herniation. There is a canal stenosis is there. The cord is significantly compressed and there is no any space. Okay. So what we do actually in the posterior cervical decompression and fusion, we will take out bilaterally from the medial part of the lateral mass, bilaterally from the medial part of the lateral mass, we will take out the whole lamina and spinous process. Look at here, this point, this one. Okay. From here till that here. Okay. This whole portion will be removed. this whole portion, the spinous process and bilateral lamina. We will take out this one. Okay, when we'll take out this one, like when we see in this one, we will take out this whole portion. Look at here. This is the lateral medial margin of the, you can say the lateral mass is this one and this one. Okay. Sorry. This whole portion. Bilaterally. The medial portion, be careful that not a single portion of lateral mass should be removed. Only the portion that is covering the canal. What is the area of canal actually? The most medial portion of the lateral mass till that the contralateral side of the medial portion of this one. This is the area of the canal. Because we are addressing the canal of this one, you will remove this portion whole. Okay, then plus minus, if there is a ligamentum flavum hypertrophy, we will remove the ligamentum flavum hypertrophy. Ligamentum flavum. But when there is no any ligamentum flavum hypertrophy, we will not disturb the ligamentum flavum. Only the congenital canal stenosis, we will not remove the ligamentum flavum. If there is a discommiation, we will not remove the ligamentum flavum. If there is a trauma, that only we will remove the posterior elements, we will not remove the ligamentum flavum. So this is some, you can say, the precautions over there. So the posterior part will be removed, this one. When we remove this one, this will be the picture of the axial section, and this will be our superior view of this one. Look at here, we have removed this whole part. Okay, now what happened after, what is there after removing this portion? Now you will draw a midline at the here, from here. I'm saying, oh sorry, suppose that there's a midline. This is the midline. Midline what? Midline of what? Midline of the lateral masses. Okay? You have to draw a line of the midline of the lateral masses. Then the four quadrants like this. These are the four quadrants. Okay? Why this is important? Anyone? Why we are making these lines?
The screw entry point
Screw
and
placement.
trajectory.
Yes, screws. We can only put the midline. Why these transverse lines over there?
For trajectory.
Yes,
Screw trajectory.
screw trajectory. Okay, good. What are the types of lateral mass screws? Lateral mass screw techniques. What are the types of lateral mass screw techniques? Yes, anyone who is appearing at the exam and any young consultant. 3 types. Dr. Sadit, yes, good. What are the 3 types? And Roy, Camel, and Magrel. Excellent, thank you. So there are 3 types of the lateral mass techniques. That's why it's very important that we have to draw a midline, because each technique have the different trajectory of the screws. Okay, that's why you have to draw a midline. Then there is a transverse lines over there. Okay, that is the 3 technique. There's the N, Magrel, and Roy Camel. So each technique has a different placement of a screw. That is about when we are saying that the midline, just you can say the medial to 1 to 2 mm medial to this midline, that will be the N technique. and that 1 mm will be the medial technique, 2 mm that is the, I think, the magral, and then when there is a straight forward over the midline, that will be the royal camel. So that's why we are placing this one. So where will place the screws ideally? Ideally, we will place the screw.
Infero-medially.
Yes, excellent. Inferior medially, this one. This will be the area that inferior medial will be screw placed. Okay, these red dots. And what will be the trajectory?
Lateral.
Superolateral would be the trajectory.
Superior-lateral view. How much superior-lateral?
20 degrees superior.
20 degrees superior. In all techniques? In and yes, Dr. Ikra, you are saying something.
It was the magral and magral technique.
Sorry? And technique? Magral technique.
Anderson technique.
Anderson technique. How much superior?
20 degree.
15 degrees superior. That is the from caudocranially. Then you have to go from 15 to 25 mm laterally. Okay, superior lateral. Okay, so this is about N technique. What is about magral? I think it is about 10 degree or 20 degree. So go there. And royal camel, there is no any trajectory. There is thought that straightforward you have to go little bit lateral. Otherwise, there is no superior one, that one. Okay, so ideally we do the N technique, that is the inferior medially, that is about just 1 mm to medial to the midline. Then we have to place the screw, then it will be about 15 degrees superiorly and the 15 to 20 degree laterally. Then we place the screw. So this is the trajectory of this one. So these will be the screws. Look at here. Inferior medially, we have placed the screws and our trajectory is superior lateral. Superior lateral. This will be the lateral side. And look at here that this is the trajectory of this one screw. Superiorly. Okay, because we have to place the screws only in the lateral masses, not going downward. When we will go downward, it's up to us that we have to see that what is the normal size of this one screws and length, because it will hurt the roots, and then it will go downward. It can hurt the vertebral artery. Okay. So this is the placement. Again, another picture that in the lateral masses screws, look at here, only the lateral masses are there. When you will go medially, there's a chances that the vertebral artery can be damaged. So thank you all. This is a bit lengthy class about today's posterior cervical surgical approaches. So any question up to here?
Thank you so much, sir.
Yes, any question?
Thank you, sir.
Welcome. You are welcome. So again, any question, go through all these approaches. Again, after reading this one and going through this one, if you have any question, just put it in put on the WhatsApp group. I will try to answer that one, and we will discuss. Dr. Kamal, are you there?
Yes, I am. I was just waiting for you to finish. Yeah, everyone, if you have any questions, any feedback, you can always leave questions on the group. We both go through the questions very actively, and we would be happy to get back to you people. So, Dr. Itzaz, do we have a session tomorrow by you?
Yes, tomorrow we'll have last session.
I'm sorry, you're not audible.
Tomorrow we have the last session of this week.
Okay.
And that will be of the C1, C2.
Okay, so we are going to do C1, C2, and probably craniovertebral junction.
Yes, inshallah.
Okay, so I'm just going to announce it on the group. Everyone, tomorrow is our last session before Eid, and then we are going to resume our rapid clinical review post-Eid, inshallah, probably from Monday or Tuesday. I'm still debating whether we want to do a session on Monday or not, but I will let everyone know on the group, inshallah. So this is a wrap for today's session. Any feedback, any questions, all are welcome. Thank you, Dr. Itzas, for joining us. Thank you, everyone else as well. I'm going to wrap this up.